Hello and welcome to Global Healthcast Special on COVID-19. This is our 6th episode today, and I'm alone today here virtually with Catherine Weil-Olivier from Paris. Hello, Catherine. Good evening.
Hello, Joe. It's a pleasure to be with you.
And this time, what we want to do is we want to review a little bit what we discussed so far. We had topics on vaccine confidence, on long COVID, we had pediatrics, we had vaccines, and maybe in the end, we discuss a little bit future pandemics. And maybe I start with Professor Karafilakis from London speaking about vaccine confidence. What I really remember from her talk was that for people, what they really worry about is adverse event. They want to trust people. And the one person they trust, this is their general practitioner, their primary care physician. This is the key person in deciding what to do during a pandemic. They want to have good data, they want to have scientific data, and she also highlighted the importance of communication. Catherine, what is your take? What do you think what was most important in this vaccine confidence aspect?
In this aspect, you have a background that is a potentially terrific disease. And so unless you are locked down totally, or on a daily basis, you have those hygiene respiratory measures more or less comfortable, then you needed vaccines. And so in this very peculiar situation of pandemic, at least within the first year, with so many consequences published in media or in newspapers, I think vaccines were expected. And I must say that all our government worked on that in a very careful manner. So you are totally right, and she is right when she says that the best place to get vaccinated is with its own healthcare professional. You are trusting, really. Nevertheless, we had so many information on a weekly basis or nearly a daily basis about what were the adverse events observed, which frequency, which age group, what were they, how the outcome was for this adverse event. So people knew where were the risks. And I would insist on the fact we should reproduce in a more routine basis for any vaccination program is transparency for events. So I would emphasize the quality of pharmacovigilance at a national basis, but also European and international basis. And that was definitely something very important. The second aspect, quite important, as media and every medical context were following very precisely the number of cases, number of illnesses, number of deaths, it rapidly happened that we decreased all those morbidity and mortality issues with the vaccines as soon as we reach correct vaccination rate. So that was the second important part.
I think you're right, and it is nice that you come up with recommendations, right? What we did well, and if I may jump on something, we can discuss this, that may not have been ideal, and I would say communication was not always ideal. Number one, there was a lot of fake news. We don't we don't need to discuss people who come up with wrong messages, right? With messages that are simply stupid. But I think at least some governments did not always communicate well. What I missed, for example, is the word that some respiratory vaccines very hardly reduce acquisition and coverage and spread of organisms. This was not said early on really in a nice way. Everybody thought it's like a measles vaccine. You have 2 shots and this is it. But that was wrong, right? This did not happen, and that when people lost trust. What do you think?
Yeah, you're right. We were, well, scientists, doctors were exactly like the rest of the population. and they knew something new every day. And so you are right. We expected that probably a primary series with 2 doses would be enough for the rest of the pandemic. Yeah. And we didn't know at that time that we would have so many variants needing some adaptation of the vaccines, and yet we should require more boosters. We started with a class of vaccines that were not used to vaccinate previously, though they were in the scientific domain for more than a decade, even 2 decades. And so we were obliged to follow, as the public, the results and to adapt depending on that. And it appeared that durational protection was probably a bit short compared with other very classical inactivated vaccine, protein-based or vector-based. And so we had to adapt. And scientific people, government people, health authorities, and the public had to adapt to what was demonstrated, I would say.
So maybe in the future, besides trust, transparency, pharmacovigilance, careful communication is important, which Emily Karafilakis really highlighted. And maybe we should also teach people, we don't know what we don't know, and nobody can predict the future. And we think that 2 or 3 doses will be fine for some time. We didn't know it is good for less than 6 months, right? So that is something we need to teach people about science. Predicting the future is difficult.
Yeah, well, one example would be to say those vaccines, we expected a lot from them. We expected that they would reduce the circulation of coronavirus. They would reduce the shedding of the virus. We would reduce the rate of infection. And what they have proven so efficacious was against severe disease and death. So it's difficult in a vaccine policy to make people comfortable with the idea that you lessen something you don't see anymore.
No, you're totally right. Let's come to the next topic, and that is long COVID. And number one, first of all, thanks again to Professor Karafilakis from London. Great presentation. And that introduces us then to Danny Altmann, a professor from France on long COVID, who highlighted that the disease is difficult to diagnose. You can get long COVID even after mild disease. We do not know yet who is at risk for long COVID. Many people are infected with SARS-CoV-2, but only, let's say, 10-20% come down with long COVID. The pathogenesis is unknown. There is no specific treatment, and there is no good general care for everybody out there in the population. This is the main highlights on long COVID. Any important point to add here or any aspect we should discuss?
Yeah, I think he insisted on the fact that one of the factors for long COVID was to have persistence of the virus. We know other diseases are able to do that. Epstein-Barr virus is able to stay in the body for a long time and have some consequences, chronic fatigue. And clearly, he worked a lot on the topic, and he showed extremely good data about the persistence of the virus in some people. What is not clear is why some people will keep the virus longer. And so it appears also that it was more important with some variants as Delta, but you still have long COVID after rather a mild COVID, and like Omicron variant or the subvariants of Omicron. And it's unfair for the public because you don't know who will have long COVID. That's for sure.
Yeah, the important point there, which you highlighted, is COVID is not only a respiratory disease. The virus may be all over the body. It is a systemic disease.
Yeah.
That is why you have symptoms from all organ systems, from the kidneys to the brain and from the muscles to your heart, lungs and everything. And I guess initially this was not appreciated, although I remember a couple of weeks after the first cases, there were pathologists reporting that the virus is everywhere. So we knew about it.
No, that's true. You could demonstrate it from autopsy for people who died, unfortunately, of the disease. And one of my queries is about why you keep it so long and why the immune response is not efficient enough to eradicate the virus from the body. So we don't know all. What is clear is that within the years, we have a more stringent definition. You require the symptoms for at least 3 months before speaking about long COVID. But clearly, some people are more prone to long COVID, and they will get their symptoms for months and months, and we don't know yet how to cure them in a very satisfactory way. And so I would think that, again, it's an argument to get vaccinated. And the idea so far is to get the vaccine every year.
Yeah.
We will see if it is efficient within a few years or even this winter. But those people deserve to be more protected, probably.
One point you also highlighted again and again is that the COVID is not only a viral disease, but also an immune disease.
Yeah.
So it is not only the virus, but sometimes it is your immune response that causes the disease.
Mm-hmm. Yeah, clearly it's a very complicated disease. It's you had thrombosis not only in the big arteries but in the very small capillaries, and so it is really a complex disease. Yeah. And there is a link between the clots and immune response and the way you have it or not in a long term, and so it's we have to understand that it's quite easy to evaluate the humoral response with antibodies. It's much more difficult to go far deeper in the cellular immune response.
Yeah, and I think this is a nice concluding remark on long COVID. And with that, we thank Danny Altmann for his wonderful contribution and go to Pierluigi Lopalco from Italy. And he spoke about the COVID vaccines, covering that COVID-19 vaccines are now booster vaccines. If you want to license new vaccines, most people have had it, right? You need it as a booster, but probably not as a primary series. He highlighted that COVID-19 vaccination will now be seasonal, that the vaccine should be given to high-risk subjects, and that in some countries, it is given universally to everybody. There are different concepts there. On the one hand, you want to prevent death and morbidity in those who are at high risk. In the US, the goal is everybody who wants to be protected should be protected. It's a different psychological approach. And finally, he highlighted how important acceptance is. And Catherine, I'm sure you have some additional points you want to discuss with vaccines.
Well, obviously, there is a family of vaccines that are still coming first within this pandemic, but I do think that we need other kind of more classical vaccines to maintain. It has been demonstrated, and this is an important point with the vaccines. Then when you are infected and you are cured from your infection, whatever the severity of the disease, and then you receive a vaccine, then your immunity is larger and you are better protected, probably a bit longer. And I may expect that it's not only a humoral response and a level of antibodies, but also a cellular immune response that is achieved either by the infection or the vaccines. The fact is that with a seasonal booster, as it is now, because it's pragmatic approach, it's simpler to consider it as we do for other winter epidemics like influenza. And so we have identified what we call high-risk groups, those people more vulnerable, whatever the reason of their vulnerability. And so obviously we know that those vulnerable people have a higher risk of severe disease. And so we need to emphasize their protection every year. Then for the other people in the surrounding of vulnerable people, it's always best to be vaccinated in order to protect and limit the transmission of a virus. And then for anyone who would be interested for any reason by the vaccine, we have no reason to forbid them to get vaccinated.
Yeah. Thanks for summarizing this so nicely, because the vaccination policies differ from country to country, and people ask, why is something recommended here and not recommended here? The scientific data set is the same for everybody, right? And all of a sudden there are different recommendations. And again, this can be explained with local priorities, with your attitude to something. It's a vaccination philosophy in the end, right? Maybe we should come up and trademark this term, vaccination philosophy, for, that different countries have different philosophies how to get things done. But
I would say, if you allow me, and this reminds me of something quite important said by Emily. After this rush on vaccines for the first year in 2021, when at least we had vaccine, there is like a flow of the sea. There is a sort of fatigue due to the vaccine. So I understand so well this notion of fatigue. People have made a huge effort to get vaccinated, even to have the first booster. But now on they feel well, the probability that they are vaccinated or have been infected is very high in the population. And so maybe we should also introduce the idea of globally in a population, at least in the North Hemisphere, we can consider that 95% of the population has, either by vaccination or disease, whatever infection or disease, they have immunity against. But yet, when your immunity is a bit frail, then you absolutely need to have boosters in order to stimulate your immunity and be ready to react in front of another infection.
Maybe I can add one aspect here, and that is everybody would agree that there is no ideal COVID vaccine yet. Would you agree?
Oh, absolutely. Absolutely. What I really consider is that the vaccine that were marketed were, whatever the kind of vaccine, were good vaccine, and they were really useful. But definitely we need more, we need more vaccines. Clearly.
And I think it is also nice to have choices and to have different platforms, and depending on your local, on your priorities, you can choose whatever you think is most appropriate, or your doctor can choose what is most appropriate for your situation. So let's thank Pierluigi Lopalco very much for his wonderful review and assessment of where we are. And let's move to Federico Martinón Torres on pediatric vaccines. And from there, I remember COVID in children is less frequent and mostly mild in children, but there are some severe cases out there, and there is this multi-inflammatory syndrome that is out there, particularly in children, that mimics Kawasaki disease. And the need to be vaccinated, that was his position, should be an individual decision. And I think this is where we left him, and maybe you have some additional thoughts here.
No, you're right. In 2021, we were really afraid by this occurrence of multisystemic inflammatory disorder. And as it is multisystemic, and those kids went to intensive care units, and cases were severe. And really, it was one of the reasons, even if it's not so frequent, and yet, as long COVID, we don't know exactly why those kids developed a very severe disease, because their symptoms previously were not as severe as expected. And so it was an argument to promote vaccination for kids. It happens also that a large majority of children were not so ill with the disease. And second, we had the habit in hospitals to test all children entering, whatever the cause of their entrance at the hospital. And many of them were carrying or shedding the virus, though they had no symptoms at all. So when you say COVID among children, probably a large population of those kids had an infection, but no disease and no severity. And why would you vaccinate a child against an infection or a shedding? When we know that the vaccine clearly didn't demonstrate a strong impact on transmission and circulation of coronavirus.
Yeah. Look, my sister is a teacher. And she was really afraid going to school with many unvaccinated children at a time when there was no vaccine. So what do we do with the teachers, right? They should be vaccinated to begin with, right? But infectious pressure in a school class is quite high. Yeah. So there are very many good arguments to get children vaccinated. But I guess most countries at this point opt right now to not routinely vaccinate children, only those at highest risk for severe disease.
Once again, high risk medical, those vulnerable kids deserve to get protected every year. Otherwise, we really consider that this is the choice of parents. But I would go back to something very important you said about the closure of schools. For kids, it was a real issue. And there are some good data from Europe and America. America closed for more than 40 weeks the schools, and they observed now on the decrease of knowledge of their kids. On the contrary, in Europe, some countries didn't close at all, and for example, France closed for around 12 weeks, no more. And I would insist also on the direct impact on a kid for the lockdown and all the measures and the anxiety of the environment. And so it's not only the possibility to get infected, but it was the mental and psychological consequences for kids. And I'm quite sure your sister observed that among her pupils.
Yeah, this is well much discussed in Germany as well. The consequences to the brain and to the mental status of children, and certainly to their academic achievements. Yeah. That is, after COVID, definitely declined, right? There is no doubt about it. And this is a harm that was not discussed, which again may speak for vaccination, right? You can open earlier if you vaccinate. But I guess the two of us have been in the field of vaccination for 2 or 3 decades by now. And we are so much pro that other people may be a little bit skeptical here. But again, it's something to consider. Vaccines can do more than just prevent disease. They can open up societies, right? This is a different benefit. Let's close up on Federico Martinón Torres.
No, there was also a presentation from Bruno Lina on surveillance, and we haven't been speaking about surveillance. And that
have not been.
No, it was a key issue, and it's very difficult to draw a vaccine policy without a very strong knowledge about epidemiology. Here, the genomic evolution of the virus, and a very precise knowledge of the variants appearing, disappearing, their virulence, their fitness to be virulent or to infect humanity. And so really, I think Bruno Lina summarized quite well. He works in Lyon. He is responsible for the center in France, and he works also with WHO. And so he was very close to the large global surveillance of coronavirus. So maybe you remember his talk and you have some comments to add to that?
Yeah, my one comment is that many countries were not really well prepared when it comes to epidemiology. And I think my main point of concern is that, at least in Germany, in the daily news, we got incidence data, which were not incidence data, but cases. And tests were done for those who wanted to see their grandmother in a nursery home, for those who wanted to go to a party, and then it was if you wanted to attend a cinema meeting, whatever. The denominator changed all the time, and we never had a clear-cut incidence, right? So this is a big disadvantage. We should have systems in place to measure incidences, or any other way to come up with good numbers that are ready for decisions. And in many countries, we didn't have that. But
no, you're right. It was quite difficult. There was a time where antigenic testing with nasopharyngeal swab was really quite a large possibility to diagnose in a population. As soon as you make those tests paid by the patients, of course, they will diminish the diagnosis. Nevertheless, I would insist on the quality of the genomic surveillance.
Yeah.
GISAID did major work.
Yeah.
And every grid center of any European country sent quite a lot of viruses and strains to GISAID in order to have a large collection.
Yeah, this is praising our science colleagues doing primary research on the virology of the virus. This was well done, and many, many people contributed. If you read the papers, it is full of contributors, and they didn't get any additional payments, right? They did this in their free time, and they did this on top of everything else they did. So this was really, really, really well done. This went well in the pandemic.
Yeah. We must consider that within a few weeks, we knew what was the virus. It was totally identified on his genome. And from there, we could build vaccines. And so really, I think it's an improvement anyway, even if it's not perfect. And we definitely can do better in this domain and maintain that on the long run. But it has been key to the development of vaccines.
Yeah.
If we didn't know exactly what was spike protein and the part of spike protein interesting for the vaccine, any kind of vaccine, it would have been very difficult.
Yeah. Actually, we just discussed surveillance and how well that worked. And finally, maybe we have one word to say. There were more than 100 vaccine candidates.
Yeah.
And they were available in no time.
Yeah.
And maybe this is another praise to those colleagues who spent all their free time and worked hard day and night to get vaccines out there for us to choose.
Absolutely.
And I think this is an additional point to mention here that went very well.
Right. I am totally right.
For the sake of time, Catherine, it is always nice discussing each of these points, and I hope we meet again very soon in Paris to discuss this a little bit deeper. But let's talk about future pandemics. And I've given a presentation on that in the past, and I think there will definitely be a next influenza pandemic. They always come every 10 to 30 years. There will be another coronavirus pandemic. We have had them now every 7 and every 10 years. So I predict there will be a fourth corona pandemic coming maybe 10 years from now. And finally, I would like to highlight smallpox as a bioterrorist weapon. That is still existing. And finally, I attended a meeting with a veterinarian. And he said there are more than 300,000 RNA viruses in animals ready to jump to humans. So the next pandemic will come. And the question is, are we ready for that? What should we do? What is your view here?
Well, the problem is that the human nature want to forget about very severe episodes. So you can see that in the population. They don't want to think anymore, and the media don't want to think anymore about COVID. COVID is still there. We all have in our country some hospitalization. So this COVID-19 is not exactly like the previous COVID you are thinking about, the MERS or the SARS-CoV-1. This one was really an extensive pandemic. It was a terrific pandemic. It was as important as the 1918 pandemic influenza H1N1. And so you are right. Nearly all, and even all pandemics come from zoonosis. And so we are getting closer to those wild animals because of climate change, deforestation, and diverse region, and probably some we don't know yet, and we have not yet identified. So obviously, we need to keep that somewhere in our mind that we will have. Are we really much better prepared? I would say that when I see the rapidity of development of the vaccines and the number of candidates, as you said just now, I think there is a hope that maybe we could be readier even next time. I'm rather optimistic.
Yeah,
but we require a very precise surveillance. But maybe the public and the media do not realize that there is a huge surveillance, both of wild animals and the poultry, anytime. So we know quite precisely. We are not very interested by this animal world. We should.
Yeah. And this is the one-word concept, to mention at least this concept that is out there. We live together with animals on one globe, and exposures are mutual, and from antibiotic resistance to pandemic viruses that may come along, we live in one world together, and we should always consider both. This is almost...
We should respect each other.
Yeah. This is almost a last final word. We live in one world, and maybe the next last word from my side could be, the next pandemic is inevitable. Let's be ready now. What would be your last thought?
No, I totally agree. I think we can't forget about pandemics now. We don't have to be afraid of them. We will have to live with them.
Yeah. This was a very good last point. We have to live with the risk of a next pandemic that is inevitable, and we should get ready now. Catherine, it was a pleasure to talk to you, to review the 5 previous presentations that we had here. And this was our last one on this series. We would like to thank our sponsor Novavax for making this possible. This was an unrestricted grant, so Catherine and I were the one to decide on what we cover, and our guests independently could express their opinions.
Well,
with that in mind,
I'm sorry. I just want to add that you are speaking on global health, and on my side, I would like to cite CLCI, and it is a coalition for life course immunization, which means protection of any age, including vaccines.
And I guess that is even a better last word. Life course immunization is important, right? Yeah. This is a very important point. Yeah, we touched it several times today, but didn't mention CLCI. What a shame. In any event, thanks for listening to us. And we hope you enjoyed our series, and please spread the news and leave your comments below, and please like or share our presentation here. Goodbye.
Goodbye, and thank you for attending.